It's hard to talk about a program that has so many different aspects to it in 20 minutes, but I'm really going to try my best to do that for you. One of the misunderstandings, I think, is that people that drink a lot on the street or chronic alcoholics or public inebriates, I think they're called in the U.S., people often think, I think the public often thinks that these people drink a whole lot of alcohol. And what's quite interesting is that many of them that get to this point actually don't tolerate alcohol very well. So it often doesn't take very much alcohol to get somebody in a very bad state. As we started to develop the managed alcohol program, we started to look at sort of simple practical things as to how we would serve and what would that look like. And we truly had to model that on individual behavior. And behavior is the thing that we kind of still hold fast on today. Somebody can drink and different people can tolerate different amounts of alcohol. One of the challenges in providing alcohol services to people is obviously flight risk. It's got to be worth it for them to stay. And if they don't receive enough alcohol, chances are that they leave, and they've left now with you starting their day by them drinking. So it's quite an important feature of the program to be able to manage what the person needs and balance that with, you know, the safety of what they're drinking. With providing services that allowed now for the serving of alcohol, it was also quite apparent to us to not only watch the individual serving and how that actually works for the person, but to manage the risks that are associated with the drinking. And we're talking about a population that up until this point, I believe, was defined as being very difficult to work with. And I think that's also a bit of a misunderstanding or a misnomer. They also get described as being very hard to work with or hard to manage. I guess what I've learned over the last 15 years that it's in fact mostly the system that is hard to manage in terms of the clients, and perhaps not the client so much. But managing drinking behavior is in fact quite easy to do. For us, it was just a simple idea that if you had something that somebody wanted, you probably had an opportunity to work with them at their level. And by allowing them to be in a place, in fact, this group, this community existed long before our program did. We simply provided the bricks and mortar around them. But they had existed in our community of Toronto for many, many years. In fact, they used to be described as Skid Row alcoholics at one point here. Interesting that a group that has been sort of ostracized or exiled comes into a program, and the biggest challenge we have today to jump ahead is actually helping people to make the next step in moving. They don't necessarily want to leave, which is kind of ironic in terms of service delivery as well. We have a hard time getting people in, and then we in fact have a hard time getting them to the next step. One of the true challenges along this way is that people get very, very sick as they get better, as their drinking patterns start to change, and we start to manage their addictions as opposed to ignore it. People don't often survive it, and this is a problem that exists, I think, specifically with this population. They're inherently unwell from a health perspective. If they're left to their own devices and surviving on the street, they won't, as made clear with Mr. Frank Paul and several others before him, and hopefully not too many after. But even with all the support in the world and a sanctuary for them and support for them, they still often won't make it, which is, it's hard for the people that provide this service in a way. In fact, over the last 15 years, our program has grown exponentially since then. We started with 10 beds. I probably should have said that earlier on, but we now have a 120-bed facility. And we lose about a client a month through palliation. So even providing all the support in the world might not necessarily mean that people will survive the experience. The other very interesting thing that's happened to us is that nobody really ever anticipated was that we have a tremendous amount of sobriety in a wet shelter, which sort of was the antithesis of where everybody was at in those early struggles. I know Vancouver has been leading very much the country in many ways around harm reduction, and my hat's off to the Portland Hotel and Liz Jensen and Evans and her group, who've done some remarkable work there. It's similarly here happening in Toronto, where we are working with a specific population of people that don't survive well even with the support. And that is kind of a magical thing for us, I think, that work on the ground, because it allows us to help those who really need the help. So while in the past we described this group as being ones that were hard to manage, what we really know now is that, in fact, maybe they're the most vulnerable. And they're most vulnerable for many, many reasons. One of the catalysts for us to think this way was about 6 or 7 years ago, we had a very large TB outbreak in the city of Toronto. And at the time, the program represented 14 active cases of tuberculosis. Generally speaking, in order to provide prophylactic medication and treatment to people that are homeless, the system has been able to do that successfully about 43% of the time. In our case, we actually hit a 98% success rate in terms of active treatment for tuberculosis, because we had a captive audience that were static, number one. Number two, we recognized that their drinking wasn't going to stop, and that if we provided them with the medication, they would be interested in taking the medication if we didn't force them to take it by not allowing them to drink. So the plan for that was to say, sir, we need you to go on medication for TB. We would like you to quit drinking. Would you be interested in that plan? Well, no. In fact, 100% of them wouldn't be interested in that plan and weren't. To reframe that by saying, we would like you to go on TB medication and we would expect that you're going to continue to drink, but if you get sick, we would like you to, we'll monitor your blood levels, and we may have to adjust your drinking. Would you be interested? 100% of them joined in, and 98% of them were successfully treated through that process. 2 were taken out of the process because they in fact got sick from the medication. So that was the example that led us to think that, in fact, this is a group that's not so hard to manage, but maybe more vulnerable in the sense that they need a lot of support in order to be successful. Many things have happened along the way. We are now doing active palliative care for an entire population of homeless men. The average age in the program of homelessness is about 20 years at this point. And I got a few statistics that I want to give you. That we started a research project several years ago with very little money. We're quite poor in the services that we provide. In fact, when we look against the rest of the system of care out there, the work that we do, we're among the poorest, in fact. But we started a research project by talking to our local police sergeant of the day, when serving alcohol was considered to be a very controversial thing in the city of Toronto. And I met with the local staff sergeant, who said at the time that we would be better off housing these men at the 5-star Royal York Hotel here in Toronto, feeding them Shiva Scotch and caviar and lobster, than we would be trying to manage them the way that we have been. Which for me, a light bulb went on almost instantly. Remembering that the program started from simply trying to care for people who were struggling in the community and on the streets, we quickly realized that we had to justify what it is we were doing through measures like the economics behind the success and the outcomes. And that sparked a bit of a research project for us that went on for quite some time, in fact. It went on for several years. And it was weighing up and evaluating a managed alcohol against the other services that were being provided. And there was some interesting facts that we knew anecdotally were true, but we had to, again, demonstrate in a very direct way.